We're going to have a Q&A now with Dr. Ming Lim and Dr. Alan Dersena. It's an opportunity for you to ask them questions in the next 20 minutes. But I just wanted to point out that this trial, the idea originated at the last conference. So that's quite a big thing to think, wow, they got together at our last conference. That's where the idea started, kicked it around, and here we are, 3 and a bit years later, 4 years later, and it's come to fruition. They're starting to recruit. So that's pretty amazing. So I have made sure that they've met one another, and hopefully they'll start collaborating and talking to one another. So this is an opportunity for you to ask questions. Who has questions for Alan and Ming? Over there.
Do they need the microphone, do you think?
Yes. And I'll repeat the question over here so it gets recorded.
What I'd like to ask is, and I don't know whether other people come up against it, but my neuro consultant, who I see once every 6 months, said, yes, you've got TM, but when I go back to see him, there's been no change in my situation, but TM doesn't recur, and you don't have a relapse in it. So therefore, it's psychological, so they refer me to psychologists, but yet we seem to be, all of us understanding that, yeah, TM can reoccur, and you can have a relapse in it. These are some of the things that we're up against with his own neuro consultants that we're seeing. Where do we go with it?
Okay, so if I understand rightly, I didn't hear all of the first bit. After 6 months, you've had what felt like a relapse. You went back to the neurologist. He's saying it wasn't a relapse. It could be psychological. Speak to a psychologist.
Well, you said you don't get relapse.
You don't get relapses in transverse myelitis. And so, was it a relapse or was it not a relapse? Could you come over here so the response could be recorded? Thank you.
Okay. We run into the same problem in the United States. There is as you can imagine, because the United States is has quite a bit of a land area, and there's a lot of very rural areas, that there are a lot of rural providers that are not maliciously giving out advice, but just giving out advice based on just a lack of understanding of the disease process. One thing for TM, I gotta tilt this up here. One thing for TM patients to think about too is just remember that that you can have what, I don't like this term, but you can have what we call pseudo exacerbations or pseudo flare-ups of the disease. Anytime, for example, there are TM patients that I've seen both adult and pediatric, that every time he or she gets a urinary tract infection or a cold, they'll find that they're weaker. And this is a phenomenon that's somewhat related to a phenomenon we see in MS patients called Udhoff's phenomenon, where when your temperature is increasing in your body, the nerve conduction slows a little bit. But this is not just specific to TM patients. So stroke patients, if they get sick, like just a cold or something, their deficit will resurge. And so I think the difficulty is for neurologists that see patients with TM is trying that are familiar with it, is trying to determine if they're having a true relapse, because there are TM patients that have true new relapses versus a relapse possibly secondary to a concurrent illness, extreme fatigue, etc. The other part of it, in terms of the communication part of it, any of the patients that I see, and this is more of a difficult question to answer, to be honest. Any of the patients I see that came from far away and that are just come to see me just as a one-time thing, or et cetera, I offer that, I would be happy to talk with any other individuals that you correspond with, especially if you have a regular neurologist or a general pediatrician or an adult neurologist or an internal medicine, what we call our GPs. to talk to them about what to expect and understand, etc. And I keep on following up my TM patients. Mainly for the point of really providing a point for them to pivot around in terms of, I'm having trouble with XYZ, is there any way you can help me? Now obviously that requires someone on the other end to be receptive to the communication, and some doctors unfortunately are just difficult, for lack of a better word. But there are some that have been receptive to really talking to other individuals and saying, oh, sure, you have a provider that I can talk with, I'd be more than happy to touch base with them. And that has worked on several levels. But it is a difficult question to answer and a difficult situation to address. And I, like I said before, my big disclaimer is I don't really have a lot of familiarity with the UK health system, so I'm not sure how strongly tied you are to your provider. In the United States, I tell someone to, well, go find someone else. I say, go find someone else. I said, if they're difficult, just say, bye, nice meeting you, but have a nice life. So, and I understand that may be a little more difficult in the UK. So.
I mean, I can speak for the kids in here, where I do see, referrals from, other regions. You're not as tied down as you ought to be, but I know it's a big hurdle to actually get a referral, and the distance it's a difficulty as well. And I think the overall sort of not necessarily solution, but one way of hopefully being able to address some of it, I think, as I highlighted in trials, is actually making sure that lots of centers are involved in TM studies and research, so that becomes bread and butter, so to speak. Yeah.
Okay. There's a question down there. You have the mic now, Rob?
He was there before.
Okay. Can you pass it to the woman down there in the corner, please? Oh, okay. No.
The thing that rules my life is fatigue. I've always been intrigued as to two things. A, what is the cause of fatigue? And why do some people get it and some people don't get it?
Right, great question.
I've never had an answer yet. So, over to any knowledgeable person who knows the answer.
Well, I won't be answering that question. I'm just repeating it. So fatigue rules his life. What is the cause of it? And secondly, why do some people get it and some people don't?
I'm wondering if the audience might want to answer that. No, I think for me, I see a lot of children, and you're absolutely right. I cannot predict who's going to have fatigue or who's not going to have fatigue. And if you look at fatigue sort of research in terms of proper muscle fatigue, and there's that Henman's principle, I'm told, not necessarily the tennis players one, but if you stimulate a muscle and keep stimulating until the point that you cannot move it anymore, that is actually fatigue. And so that's the proper definition of muscle fatigue. But if you do that in all patients with either TM or neuromuscular condition, that doesn't sort of quite meet the sort of muscle fatigue. So I can only assume that there is a programming at a sort of a higher level, or an inflammatory process that had re-triggered or programmed it differently. But I would have thought that the best people to speak to would have been Caroline, who clearly would have been the best person to comment on that. But I've heard her comment that I think, one is not clear, the drivers for that, but I think the management of that is pretty similar in terms of, as you were saying, dealing with various aspects like sleep, making sure you have a quality of life despite having the fatigue. And in kids, we have a program of them getting to school and staggered sort of integration back into school, etc.
I'll find management, I had 10 years, so it's management is my
It's just
life.
frustration why we can't explain it.
What I can do and the after effects of it. I was just interested in why something, what causes it, why something is getting this.
Do the new sort of biologics things explain that with the sort of 4-amino, 4-AP and things like that?
Well, I would say that it's different things for different people, I think. One of the things I like to stress, and I can't speak for all TM patients, but TM patients that have difficulty with walking or have to really think about their movement, our bodies were designed for a lot of these movements to be automatic, so we have to think about it. How many in the audience does not have TM? Raise your hands. How many of you, and you can keep your hands up, have ever had a really important project or work project or meeting or something that you had to prepare for like a day or something like that, or a few weeks? Okay, so I've had, a lot of people have had that. And in the days leading up, it wasn't physically exhausting, but then right after the meeting is done or whatever the project was done, you're drained. You're drained because you've been thinking about that constantly all the time. Well, put yourself in someone with TM's shoes that had to think about their walking and their movement constantly, and that's exhausting. And so a lot of that, for a lot of patients, that's exhausting. Now, when I was talking about, getting to, how the fix in terms of sleep, in terms of, managing their environment, like one of my attendings brought up the idea that just for people getting ready in the morning, he recommends that his TM patients get everything clustered, like all their clothes and everything, all in one area, so they're not going back and forth across the room 4 times. He goes, okay, you've only saved yourself 80 steps, but that 80 steps is 80 steps that you have now reserved for later activities. So then you can transport, et cetera, and that's 80 steps more. And it's little things like that help you build your, keep your energy bank a little fuller. The question of ultimately what causes fatigue is an extraordinarily difficult question. MS patients also have a lot of problems with fatigue. As a matter of fact, in certain studies, fatigue has been the #1 cause of stopping to work. It's because of the extraordinary amount of fatigue. And there's been a lot of research done in it. And so it's a very difficult question to answer. But I just like to mention those points because I think that think about your movement or how you navigate your environment with your transferring is psychologically exhausting. But because it's psychologically exhausting, just the thinking of it, it becomes exhausting.
And there will be the speaker this afternoon, Dr. Bernard Frank, who's he'll be talking about managing pain and fatigue. So you ask him that question too.
I'll go upstairs for lie down.
Somebody help him out and remember that question. I wanted to go down to this woman down here had a question. Where is the mic? I'll come right. Did you have a question?
Yeah.
I'll come right back to you.
This is a question for Dr. Alan DeSena. Okay, I want to ask you about vampire. Why can't you be on this all the time? Is it because of the loss of potassium?
In patients that can get it, and to be honest with you, I'm not sure what the availability of acquiring the medication in the UK. So apparently someone's saying that you can get it. In Scotland. Okay. In Scotland. There's Yeah, so it's in the United States. This is so as well. Is that there are certain areas where we can get it, and there are certain patients we can get it. Now, the United States has the lovely, extraordinarily complex insurance system, which I'm sure all of you have are like, that's so crazy. I don't know how anybody could live in the United States, and it is kind of crazy. And I'm just stuck there, so I got to deal with it. But there's no reason why you can't be on it all the time. There's a small risk for seizures when people are getting it, but usually that's when they just have their doses too clustered together. But there are patients that are on it all the time. As long as they can acquire it in a way that is not financially too impactful or is causing a lot of issues with their finances, then some patients are on it, and some patients have had some really positive benefits.
What was the name of that drug again?
Vampira.
I don't think it has the F in Europe. I think it starts AMPYRA.
Yeah, it's also called 4-aminopyridine or 4-aminopyridine.
That's what it's called. Okay, now I've got another quick question. It won't take me a minute. It's for Dr. Minglim. Would I be excluded from the trial because I have systemic mastocytosis and systemic lupus?
If you had an episode of TM, you would be, yes. The reason probably because that you might be on something else already in terms of an immunomodulatory treatment. it doesn't mean that your physicians should not treat you with, IVIG if they thought it was clinically indicated. It just meant that you wouldn't be able to be part of the clinical trial.
Thank you.
Okay. And it's now coming over to Sam. Thank you.
My question's kind of leading on from John as well, so it probably would have been better. I get treated at the same hospital as John, and I've come up with a similar issue to John, but it's being told that some of my symptoms are organic, but then I've got this functional overlay. And I don't know if it's just me kind of thinking, but functional overlay just sounds like, well, nothing. It doesn't, logically it doesn't mean anything. And how can you define how much of something is organic? Because I had a lesion from C2 to C8, and how much can you say is this functional overlay? How can you define that from?
Okay, so there's something about how much are symptoms organic, what is functional overlay, and what does it mean when symptoms are functional overlay?
And it's like, how can you define that something, how can you say some of it's organic, but some of it's not,
Okay.
when it all kind of ties in together with,
Yeah. Right.
works with the level of my injury. So.
I think I have to admit, I do have an allergy to the term organic, and we have a big neuroscience department that is run side by side with the neuropsychiatry department, and we see, a lot of children with a range of problems. I think for me, what organic means is that the physicians cannot explain it based on what they perceive to be, the biology or the pathology. So we take that approach that we cannot see any signs of inflammation in this, new signs of inflammation in the spine, or when we examine you, cannot see new clinical signs, and therefore, on balance, we feel that this is less likely to respond to immunotherapy as such, and that's where we draw the line. But why you get the symptoms, I really hands up and not know, other than what has been well described before in terms of pseudo relapses or extra symptoms that one gets, but they're bad terms either. So I do tell my patients that you get symptoms at certain times. Sometimes they are worse than others, but provided they don't persist and risk damaging the spine even more, we will just symptomatically manage it.
I mean, I've exceeded what originally I got told I would achieve in my recovery. So I find it difficult to kind of comprehend that they're kind of saying that some of my symptoms are in my head when I'm doing more than I got told when I was diagnosed I would achieve. Because at one point I got told the likelihood of me getting back out of bed again was slim, it was really, really poor. And I've exceeded that and done a lot, so I just can't understand why they're kind of saying, for, a long time I've suffered from depression, but I don't suffer from depression now because I've adapted my life to work around it, so I just can't comprehend this psychological side to it when I'm probably better off psychologically than I've ever been in my life.
Mm-hmm.
I think as Dr. DeSena had mentioned briefly, that I think you've got to take a pragmatic approach, that one might keep the role of the physician as someone you access when you have a problem that you think that the physician is particularly good at. For example, like, when you have pain and you need a prescription, but when it comes to telling you that you have these symptoms that are, non-organic, then you could better yourself, I think.
Okay. Are there any other questions? We have two over here at this table, and there will be a third over there. So these two, then a third.
This is a question open to all of the speakers. I know there's a period of time where the symptoms kind of present themselves. So earlier on in the presentation was 4 days as an example. Has anyone come across a patient where the symptoms came on really, really quick, like from the point of kind of the first kind of signs of it to total paralysis from the waist down? Because mine was 20 minutes.
Mm-hmm.
And I haven't read anywhere, so it's a bit scary.
Okay, I'm going to repeat the question for the video. So how quickly can symptoms come on? What's the fastest that you've come across in your patients?
So about half an hour, 20 minutes is one of the faster times. The issue is, and Johns Hopkins is really the leader in at least the United States. I'm not going to claim that they're the leader in the world. I'm not that world-centric or American-centric to claim that. Anyway, but Johns Hopkins is the leader in the United States in terms of investigating what they think might be what they call vascular myelopathies. There's a couple entities to think about. So when people say vascular, they think arterial, like a stroke, but there's also venous vascular myelopathies that can be a little bit slower in terms of how they present. There's also something called, I don't know if anyone's ever heard this, called a fibrocartilaginous emboli, where patients will get a very fast onset of what looks like a myelitis event after like a very benign trauma. I had a child that, and this entity has been described, was initially described on autopsy on certain patients, and there's actually no good way to image to determine if you had that or did have that at the onset, because it can look indistinguishable completely from a transverse myelitis, an inflammatory event. And in truth, most of those patients that have those do get trialed on steroids and often will get a second-line therapy, and some of them recover and some of them don't. It's the vascular imaging of the cord is the radiologists don't like to do it. Because usually they want to do a contrast and they don't want to give a large contrast load. B, very good visualization of the vasculature of the cord requires you to do what they call a catheter angiogram, where you have to have an interventionalist put a catheter through one of your veins and inject contrast directly, and it's technically extremely difficult, and there's not, even in the United States, there's not that many good centers that are good at it, and Johns Hopkins sort of leads the way with that. And so it's a difficult question to answer without knowing specifics, but there are people that have very fast cord syndromes. Some of them have had very good recoveries, and some of them have had not very good recoveries. In some cases, it's changed how we've approached things a little bit in the acute setting, meaning we said, well, we're going to offer this therapy, but I'm not sure of how much benefit it's going to provide. But in other ways, in terms of a rehabilitation standpoint, it hasn't changed a lot of the way we approach things because a lot of the symptoms can be the same. I'm sorry, I hope that answers your question.
Yeah.
Sorry, are you saying that the very fast onset of symptoms could be caused by one of these other vascular causes and not be normal autoimmune TM?
That's what I'm saying.
Okay.
But to be honest, does that mean that I've seen cases that were very fast onset that I thought were inflammatory? Yeah. No, because I've definitely seen cases that were very fast onset that I definitely thought were inflammatory. And were there cases that initially looked like a TM, a transverse myelitis, that evolved over about 2 or 3 days that I thought might have been vascular? Yes, possibly. It's a very difficult question to answer, and it's a very hot topic in the United States because there's really no good way to test for it. Johns Hopkins, their feeling is that there's some of these cases that represents a very subset of these patients that may affect how we address things. And so it's an important thing to focus on for the acute care moving forward, but for a rehabilitation standpoint, a lot of the symptoms are the same because if the cord is damaged, the cord is damaged.
Okay. Now passing over to this gentleman here, and then Lynn after that, and that'll be the last one before lunch. But there'll be more Q&A opportunity at the end of the day.
Thank you. Yeah, the question relates to really the onset of older age and the extent to which, shall we say, the damage or whatever, one's symptoms can get worse as you get older. That is, I had my TM back in the mid-90s. I was sort of spat out of hospital, given 5-10 sessions of physiotherapy, and that's been it. And I've sort of coped all the way without anything up until finding the society and coming to my first event today. But I'm here because I'm sort of saying, what the hell's going wrong with my body?
Okay.
And I'm wondering if age and the aging process weakens you, and your symptoms become more active.
So yeah, so what's the relationship between TM and the aging process? How do
Correct.
they impact one another?
Yeah.
Great. Who would like to take that?
So I will say that I've seen quite a few patients with older patients that had TM, and my general approach with those patients is that there is a possibility that there is an age component in terms of limiting someone's endurance and their ability to do as much as they would like to do. That's number one. But number two, that doesn't mean that we stop trying things potentially or trying to at least optimize the rehabilitation. The problem is and the challenge is that on any patient with transverse myelitis, and it's very unfair, a lifetime of rehabilitation needs has been thrust upon you or upon these individuals, and it's really unfair. And as individuals age, lots of things change. Our sleep cycle change, our energy levels change, or what we could do in terms of just our ability to stretch or in terms of our flexibility changes. That's not to say that we don't try certain things. I would say that in general, probably the best advice I could generally say is keep active. So keep active, even small little tasks can provide dividends in terms of, because it is, for any TM patient, remaining sedentary really sets you up for issues down the road. Because there's lots of different TMs out there, it's, every patient's TM is different. And so it's hard for me to say, because there are individuals such as yourself saying, well, I've been doing okay, I think. And then there are individuals that are 10 years your junior that are saying, yeah, I've been having the same problem, and it's really been an issue, and everyone keeps telling me, well, you're getting old. Well, just because you're getting old, that's ridiculous. And so, does that mean that when you're 80 years old and you have high blood pressure, you go in there and someone says, well, you're 80, so you have high blood pressure? No, it doesn't mean we don't try things. Now, I come from individuals like that I mentioned, that's the way we work, and that we try things. And so the relationship is, I guess, I'm not giving you a great answer, but so the relationship is difficult to define, but that doesn't mean that we give up on trying to optimize rehabilitation and movement goals.
Yeah. Also, at the Spinal Injuries Association stand, Joyce Sinclair is a specialist in the aging process and spinal cord injury, so I recommend you also speak with her. And the last question this afternoon is Lynn, over here, and then...
Sorry, just before you went to Lynn, and this is just a bit of humour to add on to the answer. I once went to my neurologist for a checkup when I was 50, and he did his check, and then he came back and he said, well, Sally, you know what? TM has put 25 years about on your limbs. So if you consider yourself now 75 instead of 50, you're in quite good shape. And I was just going to say, now as I approach 70, I'm thinking, oh my God, 95? How much longer am I going to be mobile?
Yeah. Okay, Lynn.
Hi there, this is for Dr. Christina. I have a recurrent TM, and I was advised to go on immunosuppressants. We tried them on azathioprine, my body didn't manage it, and had quite a fight with neurologists and local GP when suggested myclophenolate. I had difficulties getting research in Scotland to see how effective myclophenolate was. And obviously seen in your presentation, myclophenolate was mentioned. How successful is that in obviously treating?
Can you repeat the question?
So the question was of, correct me if I'm wrong, is that you have recurrent transverse myelitis and that he wants to put you on a maintenance immunotherapy to help hopefully prevent further issues in the future. Is that correct?
Yes.
Yeah. True recurrent transverse myelitis, meaning not related to NMO, not related to MS, not related to lupus or Sjogren's, those are some diseases that can all cause a transverse myelitis, is pretty uncommon and can be difficult to manage. I've only seen a handful of patients. This is because I've seen a lot of when I was at UT Southwestern Dallas, we had a ton of TM patients, and only a few were recurrent. And So the immunotherapy options are basically kind of, for lack of a better word, we're making it up as we go along. I think this mycophenolate is a not unreasonable choice. It's a twice daily oral medication. It is immunosuppressive. It's generally pretty well tolerated. You have to keep an eye on blood counts. It's that kind of thing. And there are other options that I think the group in Houston felt that in recurrent TM patients that they use a medication called azathioprine, which we found in Dallas was a little bit harder to tolerate for patients. And Cellcept is sort of not a very similar agent, but is sort of in the probably same level of effectiveness. None of them are guarantees, but I don't think it's an unreasonable choice.
And we would use that interchangeably in children, and in fact, in the last few kids that I've had with recurrent TM, some are NMO and some are MOG positive. They tolerate MMF very well with same effects as azathioprine.
Okay, well, thank you everybody for your time. If you have a question, save it. There'll be time at the end of the day, 45 minutes for Q&A with the speakers.